Okay, I think we can get started. And I want to thank everyone for coming today to our speaker seminar series. And we are super fortunate to have Dr. Rosie Xing come and present today. So I'd like to formally introduce you. Rosie obtained her PhD in cancer biology and experimental medicine from McGill University in Canada, and she received her postdoc training at Memorial Sloan Kettering in New York, followed by a research associate at Sloan Kettering as well, with her research interests in focused ultrasound and the development of targeted cancer for therapies for pancreatic cancer. Between 2006 and 2012, she was a tenure track assistant professor in the Department of Pathology at the University of Chicago. And then from 2013 to the present, she's been the Bayou Professor of Chongqing Medical University, a distinguished expert of Chongqing Talent Introduction Program for over 100 high-level professionals, which is now increased, and Director of the Lab and Translational Cancer Stem Cell Research. She's a board member of several committees, such as the International Society of Minimally Invasive and Virtual Surgery, and the chair committee member of the Research Society for Osler of the Chinese Medical Doctor Association. She's the chief consultant of health management at Chongqing Haifu Hospital and has led the medical team from Chongqing Haifu Hospital to explore and establish a model of practice, from treating the disease to treating the patient who has the disease. So she is practicing what she preaches, and involves building the health of mind-body behavior. And in 2017, she was appointed as the Managing Director of Global Planning, International Marketing, and Business at Chongqing Haifu Medical Technology. So we are so fortunate to have you here and are super excited to learn about all the new developments of Chongqing Haifu. So the floor is yours.
Thank you, Susie. Just add a note. Actually, it's this technology made me did the career change. So 2012, I paid a visit to Chongqing Medical University upon the invitation of the president, and I met Professor Wang and the research team and the Chongqing Haifu. Okay, at the time, I have one targeted drugs already had the international IP protection, and the Sloan Kettering was about to push it into the phase 1 trial. And I had a doubt in my mind that will this really work for the pancreatic cancer patient? Because my research at the time has already informed me that overcome treatment resistant is a bottleneck that we are still facing, okay, because all the existing therapies so far in the targeting the biochemical features of the cancer cells. Okay. And we know the tumor, the cancer has a heterogeneous nature. And also due to the redundancy and if you put in also the cancer stem theory, it's more complex than we think. Okay. So it's at that, point of my career, with one drug has the opportunity to enter in the phase 1 trial, and I had the doubt in my mind that that's worse to take this path. And then I had the visit. So I just finished the podcast that they was asking me, how did you get into this? And so when Professor Wang explained to me, do the demonstration showing how focused ultrasound works, I just saw a light. I was felt struck by a light, said, there you go. This is a physical force. Okay. It's fits the cancer management principle of, it's precise, it's targeted, it can be personalized. And if we can get the cancer cell, the tumors covered, everything will, cooked. About no matter the heterogeneity, okay, so it can overcome the heterogeneity. So that's the changing moment, okay. So bring back to the topic I want to share today. Actually, I'm really glad to come back to the FUS Foundation and to the UVA and have Alan sitting on the with us. So and I'm extremely happy to come back at this time because we are about to set up the first center at the University of Virginia. Okay, and I think we choose this site because of the comprehensive FUS program it includes preclinical to the translational and also to the clinical. So it has ample experience. So we've been working with the foundation and also Alan for the past year. So we are almost there, okay? And with that in mind, so my talk, and also we are, for those of you who know us, for Chongqing Haifu, we have been focused on the past 15 years on women's care by integrating this technology into the OB/GYN fields, okay, by treating fibroids, adenomyosis, we are now at the point of leveraging on what we have done in the women's care, but also accelerate our path into oncology, bring this into oncology, okay? And so I would like to share with you in this presentation the work Chongqing Haifu has done, okay? And especially the part of the oncology to show that although we've been working on women's care for the past 15 years, but we started from oncology. We started from oncology and through the clinical research. So this, I hope, I think after setting up the UVA site, we're also looking forward to set up a few other sites so we can bring this so US can actually lead the efforts of the indication expansion in the global scheme, okay? And really thank you for the opportunity. So since this is the community knows the technology well, I just want to share with you that because we're working with the ultrasound guided HIFU, okay, and it's always the question about the MRI, your lack of academic resolution. Okay, so we developed the real-time dual monitoring system with the MRI and the ultrasound. Okay, so that for the doctors who learn this technology during the procedure, they can see better and it's more safe. Okay, and we continue. So as we mount up the data, okay, with the AI, this AI enabled, so this will become better and better, okay. So this I just want to share with you, and also, the advantages of this technology, okay, is I think for this audience, it's not a new thing, but I want to stress that since we already have 400 centers set up worldwide, and we know from the real world that this, for the hospital, for the patients, the advantage of patients is evident, but also it will reduce the burdens on the healthcare system, okay? And so the safety for any technology, when we say it's ready for deployment clinically, okay, we have to show it has the safety profile. Okay, so here I listed the two studies. One is a retrospective, one is perspective, as looking at the safety profile. Okay, and both studies showed that the first technology has a favorable safety profile. It's safe, has less complications, and more importantly, it offers rapid recovery for the patients. Okay, and in the prospective trial, when we compared HIFU with myomectomy and the hysterectomy, okay, the complication rate, major complication rate for HIFU is only 0.2%. Okay, compare with the 12, about 10% of the surgery. Okay, and also in the uterine fibroids, international guidelines has been established. Okay, and here I listed some of them. And one update is that we've been working closely with the FIGO, which is considered the United Nations of the OB/GYN field. Okay, so FIGO is going to publish its very first draft version of the expert consensus for fibroid management, and HIFU for fibroids will be included in the consensus. Okay, so that'll be very good. With that expert consensus, it laid the foundation for us to bring to the even global scheme. Okay, and also this is just for example in the women's health. Okay, we're building the international consensus. There will be a guidance. So for every countries we go. So we work with the regional and the national OG societies, and we also work with the regional and the national OG endoscopy societies. So these are the doctors who will learn, experts, okay, will learn the technology. And also we work with regional and the national fertility reproductive medicine societies, okay. And so now as so these are the academic resources we bring together in the women's health, but as we move into oncology, we'll take the same approach, so it's academic driven, okay? And so that we ensure we introduce the technology and the guidance of the professional society, so the doctors can be properly informed, trained, and learned, okay? And then the well-trained specialists can deliver the service, and the patients will have a non-invasive option to choose. And also, if we say we are ready, okay, to deliver the service, will be asked, do you have an international training program ready? The answer is yes, okay? It's going to be stepwise international training program. Okay, and so this is the accumulated case numbers that Chongqing Haifu has done, which is already over 300,000. Okay, about 90% are the fibroid adenomyosis cases. Okay, but the oncology cases accumulative is over 30,000. That we have done. Okay, so here I listed the indications developed by Chongqing Haifu. So on the malignant tumor side, it's, as I said, it's over 30,000 cases, and for the benign tumors, okay, and so it's about 280,000 cases. Okay, and brought your attention that in the OB/GYN field we have 4 indications. Okay, and we just had a new breast transducer, so it will be great for the breast adenoma and also for the breast cancer. Okay, so in terms of the uterine fibroids, now we know, so the patient selection is based on the fecal staging. Okay, now we know the types 2, 3, 4, 5, 6 are good indications for Haifu. And we also know that 70 to 80% of fibroids that require surgical intervention can benefit from the Haifu. Okay, and so it's MI is used for treatment planning, also for post the Haifu assessment. But in more the commercial sites, they can use the 3D ultrasound for the follow-up to reduce the cost. Okay, for research-wise, you can use the MRI. So here shows you a fibroid, the course of a fibroid in the 10 months post-Haifu treatment. You can see the uterus is from filled with the fibroid to completely to a normal shape. Okay, and so we also did the study to show that the average annual absorption rate is about 70%. Okay, and now we know in terms of the effectiveness, okay, we know we can treat the single fibroids and we can treat the multiple fibroids, and the effectiveness is comparable to myomectomy. Okay, and before we bring this service to Africa, we didn't know whether size matters. But after we brought there, we know size actually doesn't matter. It's you can see from the MRIs, these are big fibroids, but they are hypogenic, so they are very responsive, okay? And before we go to Africa, we didn't know when we treat big fibroids like that, the absorption rate will be good, okay? But now we know, and we even have twins born after, a mother received the treatment of big fibroids. Okay, and so we have done, here I listed the rigorous research to look at the effectiveness, okay, to look at the outcomes of the, by assessing the outcomes. Okay, and also as we bring this to the clinical practice, we continue to optimize do the protocol optimization, okay, and through research as well, okay. And here I just share with you, this is a landmark study, it's a prospective 20-center trial, and it's designed by the Oxford, and it's led by Professor Lang Jinghe, and that includes 20 Chinese centers. Okay, in this trial, it enrolled 2,400 patients, and the balanced design compare HIFU versus surgery group, and the surgery group has the myomectomy group and the hysterectomy group, okay. And the conclusion from this trial is a HIFU is safe, effective, and affordable for the speed recovery, okay. And the short-term outcome for HIFU in the study appears better than the surgery. So we have already had about into the 8th year follow-up of this study. And so we know that we also publish on the recurrence, 5-year recurrence. From this study, the recurrence rate of HIFU treated group is less than the myomectomy, okay. So in terms of adenomyosis, so if you talk to the OB-GYNs, they say, okay, for fibroids, we still have a lot of way to take care, but for adenomyosis, which also affects the fertility even more, it's very hard to deal with, okay? And so now we know that MRI is also used for treatment planning and the post-treatment assessment. So here shows you the 4 months course before and after the treatment. Okay, now we know how to treat, we can treat the focal adenomyosis, as this here shows, and we also can treat the diffuse, the adenomyosis, which actually more and more patients present with this form. We have also, just like the fibroids, we have developed the MRI-based selection criteria for the adenomyosis patients, okay? And also, this is have been achieved through vigorous research, okay? And so here, just one paper shows one of study with the 18 months follow-up, okay? So we look for the symptom relief, okay? Is the menorrhagia and also dysmenorrhea. Okay, you can have a long-term symptom relief just with one treatment. By the way, the big fibroids, say 90% of the cases we done just single session. Okay, only when it's at different locations or it's so big, okay, and we will do multiple sessions. But 90% of the cases we do single session. Okay, so we have more than 3,500 babies, and the mother actually called these babies HIFU babies because these are the babies born to mothers that suffer from infertility or subfertility due to fibroid or adenomyosis, and upon the treatment with FAS, they realize their dream to become the mother. And also, there's no one case, any single case of uterine rupture. Of course, there's no scar, okay? And the mothers experience the normal course of pregnancy, and so there's no added obstetric risks. Okay, in terms of the malignant cancers, as I said, we have already done, have experience of cumulatively over 13,000 cases, okay? So bring you back to 1997, okay? So Ellen, actually, we started this with the cancer trials. So in this paper, I think this paper is the merits of its attention, okay? So this paper summarized from 1997 and 2001, okay? 10-center study experience that involves over 1,000 patients, okay? And here's the breakdown, okay? So you can see out of 1,912 patients are actually from cancer, on the cancer side, okay? And brought to your attention, in that 4 years alone, we already treated 470 liver cases and bone cancer. The first indication, first in men, actually is osteosarcoma, okay? And the breast cancer, also breast as well with the old transducer, okay? And a variety of others. You can see we also started the benign tumors, but it's much lower case number at the time, okay? And so I will focus on my lecture on few of the major oncological indications that we have the experience, okay? So with regard to the liver cancer, now we know when we apply this to the localized, early stage original HCC, and it's just like surgery, it's with the curative intent. But when we combined with chemo in advanced HCC patients, we see improved survival, okay? It can also be used to treat liver metastasis, so, a very important colorectal metastasis to the liver, which patients don't have, cannot withstand the second surgery. This is also a very good approach. And also HCCs near blood vessels or other surgical inaccessible locations, okay? So 2005, the Haifu group, the original group, okay, by Professor Feng Wu and Professor Wang, published the very first study. And this is the RCT. This is a randomized trial, compare Haifu TACE alone or Haifu plus TACE, and has 50 patients involved. And from the table here, you can see and the characteristics of these cohort of patients, they all have large HCCs. So the mean volume is like it's like 11 centimeters, okay? And also 24, mostly they are in the stage 4, okay, patients. So if you look at so it's a balanced design, and we look at, so from this study, from the survival curve, we see that Haifu provides significant overall survival benefits compared with the TACE alone, okay? And so this is the MRI evaluation of the treatment efficacy before and 1 month after TACE. So you can see it's a large HCC, and you can see the black hole, okay, in 2 months. And I would like to introduce our team in the Queen Mary Hospital in Hong Kong. And the Queen Mary Hospital hepatic surgery team is known for their work in liver transplantation, okay? So this team has published a total of 15 research papers on Haifu ablation for HCC and or liver metastasis, okay? So in 2014, the Queen Mary group published this study, okay, confirmed the survival analysis of TACE versus TACE plus Haifu for unresectable HCC. So this has 113 patients involved and has a 5-year follow-up. So this is the 5-year follow-up data, okay? And they published another study, okay, on treating the small HCCs, okay? And this was published in the Annals of Surgery, and with 49 patients, and the observation time is a 3-year follow-up. Okay, so you can see the 1 year and 3-year follow-up, it's very good, okay? And in 2013, they also published a paper compare, this is a prospective non-randomized, compare radiofrequency, but because at the time radiofrequency was already a state-of-art, a standard of care in liver cancer versus Haifu with a 3-to-1 ratio because of the advantages of RFA at the time is already known, okay? So this is on the recurrent small HCC with 100 patients. Okay, and so it's a small. The size is rather small. Okay, and the Haifu the procedure-related morbidity is also Haifu has a significantly lower and a shorter hospital stay. Okay, and we found no significant difference between the Haifu and the RFA on the disease-free survival and the overall survival during the 3-year follow-up. Okay, so this is a case report. Okay, from this study. Showing the 3-year follow-up, a stable disease. So the Queen Mary Group in 2021 published a review article summarizing Haifu for HCC in different locations, okay, and such as the liver dome and close to the rib cage, near large blood vessels, near heart, and adjacent to a hollow viscera. Okay, so in early days when we performed the Haifu, you have to cut the rib cages, okay, but this is no longer the case. You don't have to do that, okay. And so this is an example. Slides I borrowed from Professor Zhang. Okay, and so this is done at EIO, and showing that HCC adjacent to major blood vessels, okay, which is non-resectable, can be done by using Haifu. Okay, and this study published in 2022 was done by the Fudan University Haifu Center. It's utilize Haifu for metastatic liver cancer. And this is a retrospective multi-center study looking at the colorectal cancer liver metastasis. Okay, and look at the survival and perform the survival analysis. So all patients receive the chemo after the Haifu. Okay, so this is shows the Haifu for the CRLM patients provide the survival benefits. Okay. In terms of the pancreatic cancer, okay, so the management of the pancreatic cancer, okay, is so this is statistics. I won't go into it. Okay, so now we know that these are the entry points. Okay, that we can utilize the Haifu, and the first is for the palliative pain management. Okay, because pancreatic cancer patients suffer from the pain. Okay, therefore their quality of life is very poor. Okay, so this compared with the liver, I would say pancreatic cancer is the priority indication for Haifu. Okay, and we can also use Haifu plus chemo for advanced non-resectable pancreatic cancer patients with the goal of reduce the tumor burden, to prolong the survival and to improve the quality of life. Okay, and also it can be used as a preoperative procedure to increase the surgical resection rate, because the surgical resection rate for pancreatic cancer, despite all stages, is only around 20 to 30%. Okay, so this is in 2005. The original Haifu team published the first report, the feasibility of Haifu trial for pancreatic cancer involves the 8 patients. Okay, so here's the MRI imaging. Okay, after that. Okay, and there's another major site for the pancreatic cancer is the Fudan University and Professor Meng. Okay, so this study is published in 2013, and so this is the safety evaluation. It's a retrospective study that involves 224 patients. And from this study, it shows Haifu is a safe and non-invasive treatment for advanced non-resectable PCA patients. Okay, so the treatment aim for Haifu non-resectable patients is to reduce tumor-associated symptom burden, to reduce the mass of advanced primary PCA, and to improve the quality of life and to prolong the progression-free survival. Okay, so the Fudan team also published this paper study in 2013 to show the efficacy. Okay, so this is a retrospective study looking at the HIFU versus HIFU plus gemcitabine. Okay, so the pain relief is achieved in 80% of patients, and the HIFU plus chemo confers better survival. Okay, so this is the data summarize this study. Okay, and the same team also published a bigger study in 2015 and looking at the metastatic PCA, okay, also gemcitabine refractory, okay. So in this study, they showed the pain relief rate is around 60%, and the HIFU plus the chemo confers better survival than the chemo alone. Okay, so here's the median survival and the progression-free survival data, okay, of this study. And another important major site, HIFU site for pancreatic cancer is Sloan University, okay, led by Professor Strong. It's an interventional radiologist, okay. So they published, this is their first paper published in 2018, is a case series, reported 50 cases of late-stage PCA, okay. And they also reported 85% of pain relief. And they look at in this study, the tumor burden reduction, okay, and also assess the disease progression as a secondary outcome, and also survival as the secondary outcome. Okay, and we have another site in Bulgaria also does pancreatic cancer. So this paper published in 2022 is the two-center retrospective trial showing that improving quality of life in pancreatic patients in European patients. Okay, so it's 80 patients. So this is the study design. Okay, so here they look at the pain relief after HIFU is persisted during the 6 months follow-up. So it's not just a transient effect, actually has a long-term effect of pain relief. Then in this study, they also look at the improvement of global health status, physical, emotional, and social functioning after the HIFU. And this effect also persisted as a long-term during the 6 months follow-up. Okay, then they look at the negative side of the symptoms, okay, like fatigue, pain, and appetite loss was significantly improved and persistently during the 6 months follow-up, okay. So in this slide, I summarized the 10 clinical sites in terms of pain relief. So you can see pain relief as being reported, okay, from 80% to 100%, okay? And also the mean survival. I remind you, these are all, most of these studies, the patient cohort are stage 3 or stage 4 unresectable patients, okay? So the mean survival is quite good, okay? And so the prolonging of the survival has been seen in all these sites. And I think the Vaughan Center is going to publish its under review that look at the stage 3 patients treated with HIFU and the chemo. It's already extended the survival into 43 months. Okay, so this paper is it's under review right now. So this is I think this is Professor Joan Vidal. You all know very well. Okay, he published this paper in 2015. With a four-year follow-up, and then we see this is the best survival data we see, okay, is the chemo plus HIFU, okay. So this is the screening and also the design, okay, okay. So it shows the 1 year survival. So it's a 4 years follow-up. So this data is impressive, okay. So I keep asking him why this data is better than the other sites. Okay, and because this is the best data we show, he says probably is the patient selection has to do with this. Okay, and so this is the Professor Moon. So this, I think, is the largest retrospective study looking at the gemcitabine and gemcitabine plus HIFU with a 2-year follow-up. Okay, and so since we already know the clear advantage based on the prior studies, so the design of the study is tilted towards the combined therapy, and you can see most of the patients enrolled in this study are the stage 4 patients. Okay, 70% are from the stage 4 patients. So here we look at the 6 months, 12 months, and 24 months overall survival, comparing gemcitabine alone and HIFU plus gemcitabine. Okay, so HIFU shows the benefits of the survival. Okay, and so the Fudan group also published in 2023 the HIFU before or after the chemo. In this study, 192 patients enrolled. Okay, and so this study tried to show the sequence. Okay, which one is better? Okay, so the HIFU treatment prior, so it's better to do the chemo before HIFU from this study, okay, from the median overall survival. Okay, then in last year, there's a paper came out. It's called 4-country respectful analysis of HIFU for non-resectable pancreatic cancer. So this is the German group, the Bulgarian group, the Spanish group, and also the Chongqing Haifu group. Okay, I think what's important. So this is the study design. Okay, and I think what's important is it defined the main indications for HIFU in terms of patient selection criteria. So inoperable locally advanced PCA, primary metastatic PCA, and recurrent following previous surgery selection. So these are the patients that good patients can be selected for HIFU. And also symptom criteria is the pain, local symptoms, and deterioration in quality of life. And also the safety criteria is also established. Is those lesions more superficially located tumors, 5 to 10 centimeters from the major blood vessel, not in the close proximity to critical structures, and also accessibility through the ultrasound visualization, means we can see it. Okay, and also define the success criteria after what we consider HIFU is effective. Is the symptom relief or elimination, okay, and improvement of quality of life, tumor mass reduction, so that's a secondary, and also prolonged progression-free survival as a secondary success criteria. So I think so therefore, when we apply this technology to pancreatic cancer, okay, I think we have the experience and also have these clinical studies has lay a good foundation for us to move forward with the better designed randomized trials. Okay. So timing for the timing of HIFU. Okay, for non-operable patients, HIFU performed between the first and the third cycle of the standard chemotherapy. And for borderline resectable patients, HIFU can be performed as a new adjuvant procedure prior to surgical resection. So that will increase the resection rate. Okay, breast cancer. Okay, so I will skip the fibroadenoma and focus on the breast cancer. So as I said, as early as breast cancer was one of the very first few indications we explored. Okay, and so this paper was published in British Journal of Cancer in 2003. Okay, and this is a randomized trial look at mastectomy versus HIFU in 248 patients that have early stage of breast cancer. Okay, so here's the patient characteristics. Okay, so here's the radiological results. Okay, and here's the use of the SPECT. Okay, before and after HIFU, and then so even the HIFU group also when the tumors were excised out. So this is the gross anatomy of the treated area. Okay, so here shows the margin, okay, the tumor, treated tumor and the normal breast tissue, okay. And also the pathological results also confirmed, look at the treatment margins, okay. And also look at through the cellular morphology to confirm that after HIFU treatment, okay, we see the necrosis. Okay, and we in the early studies, okay, here I just share one. We also look at the changes in the molecular markers of breast cancer after HIFU. Okay, so this is in the RCT trial. We look at the PC for markers for proliferation, for adhesion, the MMPs, the ERBs, and the telomerase. Okay, so this is the to show that these molecular markers, the expression of these molecular markers are suppressed after HIFU. Okay, so we also so here is the list of the studies that we published and done with the JC or the JC 300 system. Okay, so in the breast field, okay, when bring this technology for treating breast lesions, whether it's benign or the cancer, we are not the only one. We started early, but then we focus on the uterine fibroids, adenomyosis. So there are other groups like the French group, okay, the Selection has done a lot of work, okay. So here I share with you, it's not all the work we done, okay, but from the field, this systemic review has already looked at the safety of HIFU procedures in breast tumors, okay. So the margins, so when we look at the applying this for the breast cancer, the ablative margin, whether we can establish the clear ablative margin is very important. So it shows that we can achieve that, and also the favorable safety profiles has already been established. Okay, and in this systemic review. Okay, look at the clinical applications of HIFU in the treatment of breast cancer, and it shows that HIFU can be an effective non-surgical technique for high surgical risk patients and for breast conservation therapy. Okay, and HIFU has been applied for treating different localized breast cancer that including invasive lobular carcinoma, ductal carcinoma, and also HIFU, the outcome in the breast cancer patients, okay, to look at necrosis, okay, can be achieved in 90 to 100% of the cases, okay, and we see volume reduction in 90% of the cases, and also 90% disease-free survival at the following-year follow-up, and 89% of recurrence-free survival at the 5-year follow-up. Okay, and also here in this review, systemic review, a review shows that HIFU could be an option to obtain complete or partial ablation and can be used to treat any residual tumors after chemotherapy or as a salvage therapy in case of recurrence after the breast conservation surgery. Okay, and also look at the histopathological comparisons, and also in this study, they did a comparison. It appears that ultrasound-guided HIFU has a slightly better results compared with MI-guided HIFU. Okay, so the future research in terms of bring this for breast cancer is that Haifu is currently still considered investigative technology, okay, and with the promising potential for integration into the current cancer treatment, both curative and palliative, okay. So the ongoing research will aim to use Haifu to enhance the effectiveness of the parallel treatment for radiosensitization, immunization, and also drug delivery in cancer patients, okay. And the future studies are also necessary to establish the accurate ablation margin of detection to establish a reliable imaging modality for the follow-ups and also to evaluate the effectiveness in the treatment of a multifoci focal disease. Okay, and last, I want to share with you the bone cancers. Okay, so this technology has been used for limb salvage in terms of osteosarcoma and for pain control regarding the metastasis, the bone metastasis. Okay, so in 2010, this paper was published. The original team by Professor Wang and Professor Wu published a study looking at the stage 2B and 3 primary bone malignancy with 80 patients with a 5-year follow-up. Okay, so here, so this summarized the overall survival data. Okay, and also not separating the 2B and 2C overall, and look at the stage 2B and stage 3. So obviously, in early stage patients, when you do that, the survival will be much better. Okay, and this is the case to show you in a 12-year-old non-resectable pelvic osteosarcoma successfully treated by Haifu. And so here is the number 2 case is when this girl was first received the treatment in 1999. So that's back in the very early days when we brought this technology to the human trial. Okay, so 3 months after, okay, so she had a recurrent osteosarcoma. Okay, if it's not this technology, she will have a high limb amputation. Okay, so 3 months after the treatment, she can stand up. So this is 10 years after the treatment. She walk up the stage, okay, and dancing with her like a one leg. Okay, so in this video, so that's at the 10-year. So now she is she lived a normal life, got married, and have children, and now she works at the Haifu. Okay, yes, okay, so yeah, so bone metastasis, just because of the metastasis to the bone, also the pain is impact the quality life of the patients. Okay, so here shows you that we can treat. Not all bone metastasis can be treated, okay, but some of the metastasis can be treated by the same time. The pain score, the pain can be managed, okay. So this patient has a 8 to 10 pain score, okay. And also in this case, this is a case resistant to chemo and radiation, and the pain score is a 10 on 10. So after the Haifu treatment, the pain score dropped from 10 to 1, and it lasted during the whole 6 months of Haifu treatment. Okay, so again, this is the another case of bone metastasis resisted to also have a high pain score, and the pain dropped after the Haifu treatment to 0. Okay, so that's on the academic side, what we've done. Okay, so I just want to share with you some of the statistics in terms of on the ground and on the commercialization side. Okay, so this shows you we now have 270 leading hospitals across mainland China that has set up the Haifu service. So here's some of the list. Okay, and we have exported to 32 countries and regions, and so cumulatively have 300,000 cases treated worldwide. So these are our international sites, okay? And so we are leading provider of total solution and medical service. So here, this slide summarizes our total solution, okay? And we also built the telemedicine service. And so this is, we offer this to do, so this is telemedicine, through the telemedicine service, actually we'll do, it's linked already to 270 our global sites, okay? And through this, we can, 70% of the maintenance, system maintenance can be done, use this, okay? And then if it's a full post-maintenance package, we also provide twice a year on-site complete checkup and the full coverage of the replacement, okay? And we also utilize this term for advanced training and remote clinical support, okay? Because any clinical sites, especially in the real practice, not in research mode, they are not, you cannot depend on every patient comes in that fits the learning curve of the doctor at the time. So we utilize this system for any difficult cases beyond their capacity and to send to us for treatment planning, for clinical support, and utilize the opportunity to provide on-site remote clinical support. And it's merits to mention that this is the telemedicine service is compliant to international standards and the regulations for data transfer and the patient privacy. So by setting up the center here, we also work closely with the UVA to clear all these, to comply to the regulations here, okay? And also, we enables remote collaborative surgery. So here shows you, we can, Professor Chen from the Haifu Hospital, and through the, did the remote operation, okay, Haifu procedure at the 2 remote sites. So we can actually control, do this any site if it's open to us, okay? And in this year, this is the newest site. So this is our world's first multinational 5G focused ultrasound surgery. So on March 8th, Women's Day, Chongqing Haifu Hospital successfully performed the landmark operation, the world's first international 5G remote focused ultrasound ablation surgery, over 6,000 kilometers between China and Kenya. Okay, so this is the, yeah. And as already mentioned, you know, the international training program and the certification has been developed. Okay, so the training program is a stage-wise, but also in China, we have now 13 training bases established to receive the foreign international doctors. Okay, so that you can pretty much complete about 1/3 or half of your learning curve in China. Okay, so this is hands-on, it's not just observational, okay? And also, once we set up a center, such as the UVA site, we'll send a senior health specialist to work with the local team up to 6 months. If on the research basis, that can be even longer, okay? And after the expert has accumulated over 100 cases, so then we also offer them the opportunity to come back for advanced training. Okay, and so Neil visited us, and he was impressed with how many health specialists we employ. So out of the 600 people in Chongqing Haifu Medical, over 120 are medical doctors. We call them Haifu specialists. Okay, and those who we send out to support the international site has all. At least they are the senior health specialists had performed at least over 2,000 cases for international support. Okay, and the training program and the certification has already, its training program has already been endorsed by APAGE and the ESG in the OP-GYN field. Okay, and so when we move into the oncology, we are also going to work with the professional societies to endorse the training program and to work together to build the training program for that specific discipline and for the joint certification. Okay, so I finished my lecture with, the take-home message on, people always ask me, so I say, how can a Chinese company, okay, lead the clinical development in this field, okay? So I think the take-home message on the list is that, I summarize the industry is innovation, focus the innovation, pushing the limits of the innovation, okay? And the second is very important is the patient's benefits first. Okay, just as Sir William also says, diseases that harm requires therapy that harm less. So treatment, minimize harm to patients is a core business value of Chongqing Haifu Medical. Okay, and last but not least, I think only good medicine brings good business. Okay, so it's not a business ahead of the practice. Rather, we have to do good medicine, especially at this point. Okay, and I think over focus on the business is not the right. So we have always take the approach of good medicine. Okay, and thank you all for your attention.
My gosh, Rose, that's
Answer any questions that you may have online or on site.
Does anyone have any questions?
I have several questions.
Yes,
Yeah. That's a lot of coverage. I feel a little embarrassed when you throw out numbers in the thousands. We treated 40 here or 20 here in total. So, but anyway, for the pancreatic CA, is it treating the primary tumor or is it nerve ablation?
No, treating the primary tumor.
You try
Yes.
for
Yeah.
pain control.
Not only for pain control, but also for volume reduction.
And that helps with the pain without
The pain. So I think I think pancreatic cancer is really the priority indication for this technology. So pain relief, as I listed, is seen in all sites. Okay, and it's very consistent. 80% to 100% of patients will benefit from the treatment.
interesting too that the data suggests treat chemo and then Haifu versus Haifu then chemo because Haifu you think not only ablate but maybe disrupt cellular junctions and get the chemo in, but not so much, huh?
Actually, there's an active area. I think the foundation is also very interested in. Actually, the whole committee is interested in is the stimulation of the immune response after Haifu. Okay, so of course, when we integrate this into cancer management, if you think about locally advanced disease or like a 2B, 2B and a 3A type, so the sequence, whether it's Haifu first or the chemo first, I think it need to be worked out. Okay, or the radio. But I think, probably from at least the pancreatic cancer with chemo, looks like Haifu prior to the chemo is better.
And the last question I have is I'm thinking about the international support that you offer, but because of the 12-hour difference?
There's no 12-hour difference. It's with our doctors on 3 shifts, on shifts.
You have 3 different shifts.
Yeah, because they can also work on their mobiles. Okay. So, but in our Mexico center, that's a 14-hour difference. On the East Coast, it's only 12. There's 16-hour difference. So, time difference doesn't matter.
So treating a patient at 2:00 in the afternoon, it can be
2:00 in the morning. We also support. Yeah.
Hi, I'm Lynn Dangle. We've met.
Yeah, Lynn. Yes.
I do breast and melanoma.
Yes.
So that was an awesome talk. Building on what Alan was asking about the timing with chemotherapy, what about with immunotherapy?
We have a little experience with the immunotherapy. Okay. And I think, I will say there are few trials, ongoing trials in pancreatic cancer and other type of cancer looking at a combination of HIFU with the immunotherapy. Okay. So we don't have the results published yet. Okay. And I just add one thing about the breast cancer. So now we came back to the breast cancer and the fibroadenoma because we have a brand new breast transducer. Okay. So it's more superficial. So the JC300 system we're going to bring to UVA, it's interchangeable. Okay. So and also the JC300 system has the underwater camera. So you can monitor the treat area, on screen. So to ensure the skin is safe and that. Okay. And also it's, so for the breast, the statistics of with the new breast transducer for fibroadenoma, if you're a breast surgeon, you give local anesthesia. Okay. So the treatment time for each fibroadenoma after the local anesthesia is 9 to 12 minutes. Okay. So it's very fast. Okay. And so this will be, so I think with this new transducer, it's going to be a very good option for the breast surgeons and for the radiologists, interventional radiologists. And another thing is I want to share is that, I know in US, most of the, because of MI-guided HIFU, the specialists who get on to work with this technology are the radiologist or interventional radiologist. Okay. And, but in our experience, when we move this to oncology, okay, we think the interventional radiologists are a group of doctors. They are very versatile. So they are the ones can do the indication expansion very fast once they learn this technology. Okay. So I think the interventional radiologist is going to play a very important role. Okay. But we also appreciate that in our experience, when we bring this to treat the breast disease, to get the breast surgeons on board, it's also very important. So because it's ultrasound guided and, so you don't need to be really, in the hospital setting. So that also give a flexible setup so that we can accommodate different, experts to learn this technology. So our philosophy is to give to the technology to the specialists who take care of the patient and allow them to integrate this into their service. Okay. And we never push them, say how you can just treat HIFU. No, we don't. So that's probably one of the good things we did. Yeah.
Question, and maybe a couple questions. So since you're not using MRI for target verification, how are you using ultrasound to verify that you're treating where you intend to treat on there? What kind of model?
So, first, so we have developed the MRI and the ultrasound fusion technology. So MRI, we treat MRI, so it's a fusion. Okay. So, this is one thing. So in fibroid and adenomyosis, it works quite well. Of course, as we have more and more data coming, okay, so AI in labeled learning, AI will play a very important role in down the road, okay. So we're building a big AI program, or we call the industrial AI, means make our modality more AI, okay, and then we call the clinical AI. So that is how we can identify the lesions for the doctors more automatically, okay, instead of them trying to, search for that. And also how to do fusion technologies down the road. Into cancer, you not only MRI, but with CT as well, okay. And then another thing is that now we utilize the grayscale changes as the indication and the real for the to see the immediate effectiveness. Okay, but we know when it turns has a grayscale changes, definitely you will have underlying necrosis. But even some of the lesions don't have obvious grayscale changes doesn't mean you did not induce the underlying necrosis. So we are also developing not use a diagnostic ultrasound, but a therapeutic ultrasound for the monitoring. So that's in progress. Yeah.
So you're monitoring the tissue stiffness in order to tell what you've treated?
No.
Or are you doing cavitation monitoring?
Yeah.
Cavitation.
Cavitation.
Okay.
Yeah.
Right.
Yes.
And you can use that irrespective of different tissue types like uterine fibroid or liver.
Okay, so you talk about the clinical protocols. Yes, so each tissue has a unique features. Okay, so we talk about the biological focal region for each tissue. Is defined slightly differently. So yes, so for clinical protocol, we have to work out the dosage effect. Okay, so such as for the breast, it's very different from the liver and from the fibroids. Yeah. Okay. And another thing I think worth mentioning is that you keep asking me, said JC300, do you only do thermal ablation or you can do histotripsy? Happy to share with you that. When we always say when we do the ablation, actually it's a mixture of ablation and the boiling histotripsy. Okay. And, but, JC300, we have both, we can have these separated. Okay. In the same interface. That means, the operators can do a cocktail. So for breast fibroadenoma, histotripsy is excellent. For liver, histotripsy is excellent. But when it's come to cancer, you need a cocktail to make sure you ablate them afterwards so all cells are dead. Otherwise, with the histotripsy, even non-boiling histotripsy, you will have the risk of having live cells. Okay, and then if it's cancer, the benign conditions doesn't matter that much. But if it's in the cancer, especially early stage cancer, you have the live cells, you destroy their tumor environment. You even have probably some of the blood vessels shredded. So the long-term outcome of histotripsy alone is not there. Okay, and it has a risk of when it's come to the cancer. Okay, so by having the combination, it's the best. So you just make sure. So thermal ablation will clearly establish the surgical margin. But at the same time, you utilize the histotripsy to do it fast.
When you're doing the ultrasound guided focus ultrasound, you're watching the bubble clot in the area of
Yeah.
So instead of seeing a thermal map like you do with MR, you see a bubble cloud.
Yeah.
And that means basically the tissue's boiling. And
so even in thermal ablation, you'll still get a bubble cloud that you can track.
Yeah, you do.
And the issue is, even with histotripsy, the magic sauce is how do you disrupt the cells without disrupting the proteins.
Yes.
Because you would like the proteins exposed to your immune systems, your CD4 cells, etc., to potentially kick on your own immune system, maybe have some effect. And so there's no question that you can even use histotripsy so much that you denature proteins. So the perfect formula is how do you kill the cell, the proteins around, so your scavenger and your immune system can sort of pick up on them, and then timing the immune therapy so you don't kill your own immune cells or paralyze your own immune cells so that your system can pick up and go.
Yes.
So that's what we have to figure out.
So now I think, because this campus is so strong in fast and immune therapy. Okay. The commission. So when we bring the system here, it will be very interesting to look at that. And the reason is JC300, we separated histotripsy, from the ablation, is just to allow in the oncology trials to do the mix. So such as you can just do histotripsy to release, just part of it to release the antigen, okay, and to work with the immunotherapy. At the end, you blade it. Okay, in this way, you get the immune response, and at the end, you covered everything. So this allows you to do a lot of combination, considering combine with the radiotherapy, with the immunotherapy, with targeted therapy. Okay, and so it's more versatile. So that's one we call the cocktails. Okay, and then Neil says the dream machine. They always said, "What is the dream machine?" Okay, so I think that this is come one step closer to his dream machine. Okay,
It's a little bit like AI technology. You can have 100 different AI technology, but to increase efficiencies, to have 100 AI programs running to help you, it's versus 10 different focus ultrasound machines. The dream machine is the one that can do a little bit of thermal with a little bit of histotripsy, smaller lesions like in the thyroid, deeper lesions like sarcomas that Lynn's interested in.
And also as we get the AI program going, I think it will be very interesting down the road, use the AI to help us to identify what type of to do the analysis and to come up with a good combination of, say, this patient with this makeup of the cancer, do the histotripsy first for that, then ablation, and okay. So I think when it brings it to oncology, at this point, there's a lot of options. Okay.
So the other question I want to ask you, and Susie, you may know the answer to this as well because you have more experience treating fibroids than I do. You caught my attention when you showed the pictures from sub-Saharan Africa, because with MR-guided focus ultrasound, I found that unless it was this perfect Funaki, one fibroids, that once you get above about 500 cc of volume, you just couldn't treat enough. And you said that. So tell me more about.
Yeah. So that has to do probably because the fibroid was the first indication approved by the US FDA. So there's the cap on the total energy you can deliver. Okay, so that means the energy power you can deliver is limited. Okay, so
the part of our trial, we could manually adjust the energy we want to use, and it was basically what the patient would tolerate.
Oh, okay. So do you do that with sedation or with the
sedation?
Okay. I got the answer. Because Gina when I was in with Mayo, I talked with her. So the problem is with the so with us the firing or what we call the cycle. Okay, if we use histotripsy, that's milliseconds. Okay, so it's very short. But even with our thermoablation, we said 1 minute on, 2 minutes off, or so you can decide this sort of thing. So 1 second is tolerable versus the MRI treated because you have to wait for the temperature mapping.
28 seconds.
So that patient is really, really painful.
Okay, so it's one I saw in the literature that it's 1 to 3 seconds worth. Okay, and that's because the patients can tolerate the higher energy because it's
so you can adjust. Depend like for fibroids, especially for adenomyosis, especially for fibroids that's posterior fibroids are more sensitive. Okay, and for adenomyosis, during the treatment, patients are. The tolerance of patients, you really have to pay attention to. Okay. So you can adjust the treatment frequency. Okay. Whether it's 1 minute on or 1 second on, 2 seconds, off and 5 in a cycle, or 2 minutes on, 2 minutes off. So you can adjust based on the patient's, cooperation. Okay. So, but the oscillation protocol works pretty well. Okay, so
it must, because in the pictures you showed, the pre and post, some of the pre's, I saw a lot of bowel in front, anterior to the uterus, On the post, I saw a huge bladder pushing the bowel out of the way. Most of my patients could not tolerate a bladder being that big for the treatment to push the bowel out of the way.
So do you use the balloon?
We
use the balloon. So with us, we use the balloon, which and also the inflate of the bladder or deflate the bladder to
pictures the bladder were highly inflated, pushing the intestine out.
Yeah.
That's what I noticed. But in the U.S., our patients won't tolerate the bladder getting that big.
Oh, but we don't inflate the bladder only when it's needed to push the bowel away. Okay, and then but we also have a balloon, so you can physically place the balloon. Okay, then adjust the balloon so that as long as there's no adhesion due to the prior surgical conditions, so you pretty much can push the bowel away.
The other question I have, I heard you say you now have a camera in the water that's in the water bowel.
Yeah.
So it actually can be looking at the skin to see if it's turning red?
Yes.
Okay.
Yes. So before, we always ask the nurse to check pancreas. But if you choose the select the patients well, we have a very clear patient selection criteria. Okay. So if you follow that and follow the training and follow that, I mean, the skin burn in our retrospective study, it's only like 0.1% or something. You barely see that happens. Okay. Unless there's a scar, such as they do the liposuction, you have to pay attention. But these, you do the pre-screening. When you do the simulation, we call the simulation, session, you will be able to tell whether these patients are fit for HIFU. Okay.
Thank you for answering all those questions and for sharing all this amazing advancements that your company is doing to help treat patients. So thank you so much.
Thank you. Thank you, everyone.